Hello everyone. Today I know Marissa Sain and my partner Jasmine Sabanel will present a case study report which is phaco emulsification with multifocal intraoscular lens insertion OS, which is osculus sinister extended depth of focus. For the demographic data, name of the patient is Luna Estela Di Castro, 63 years old, and date of birth is March 16, 1962. Sex is female and she is married. Address is unknown. Overview of medical diagnosis. Admitting diagnosis is mature central posterior subcapsular cataracts OS. Past medical history. No history of previous eye surgery or ocular trauma. No significant systemic illness reported. Present medical history. Gradual worsening visions, glare and difficulty reading, diagnosed with mature posterior subcapsular cataracts. Chief complaint. Progressive blurring of vision in the left eyes, especially when reading and exposed to bright lights. Proposed surgery. Phaco emulsification with multifocal intraocular lens insertion is a modern cataract surgery in which the cloudy natural lens of the eyes is removed and replaced with an artificial intraocular lens. During the procedure, ultrasound energy is used to break the cataracts into small fragments, which are then sectioned out through a small incision. After the cataract is removed, a multifocal intraocular lens called an extended depth of focus lens is implanted to restore the vision. The EDOF lens is designed to extend the range of clear vision so that the patient can see at far, intermediate, and sometimes near distance with lens dependence on eyeglasses. This surgery is commonly performed in the left eyes, also known as OS or oculus sinisters. It is considered safe and effective in improving visual functions and quality of life for patients with cataracts or phoveria. Studies show that EDOF intraocular lenses can improve visual activities, visual acuity, and patient satisfactions by increasing the depth of focus while reducing the visual disturbance such as halos and glare. The final diagnosis is mature central posterior subcapsular cataracts OS. Surgery performed. Definitions. Phaco emulsification with multifocal intraocular lens insertion is a modern surgical procedure commonly used to treat a cataract. During the procedure, the surgeon makes a small incisions in the cornea and inserts a specialized probe that emits ultrasonic energy to break up the cloudy natural lens into tiny fragments. These fragments are then removed from the eyes through suctions. After the cataract's lens has been completely removed, a foldable multifocal or extended depth of focus intraocular lens is implanted into the capsular bag to replace the natural lens and restore visual function. This technique uses very small incisions that are usually safe-sealing, which helps reduce surgical trauma, promotes faster healing, and improves post-operative visual recovery compared to traditional cataract surgery methods. Simple descriptions of the surgical procedure. Preparation. The patient was brought to the operating room and probably identified. The operative eye, left eye, was confirmed, which is OS. The periocular area was cleaned using aseptic and antiseptic techniques, and sterile drapes were placed to maintain a sterile surgical field. Type of anesthesia. Local anesthesia was administered. Topical anesthetic drops were applied, followed by an intracameral injection of 100% lidocaine into the anterior chamber to provide adequate anesthesia and patient comfort throughout the procedure. Positioning and preparation. The patient was positioned supine on the operating table under the surgical microscope. A sterile lid retractor was inserted to maintain eyelid separation and ensure optimal exposure of the operative field. Incision. A small step incision was made at the superior and inferior limbus. A temporal clear corneal incision was then created using a keratome to allow the entry of microsurgical instruments into the interior chamber. Lens capsule opening or capsuloresis. A continuous curvilinear capsulorhexis was performed to create a circular opening in the anterior lens capsule. This provided access to the cataractous lens while preserving the capsular bag for intraocular lens implantation. Lens fragmentation and removal, phacoemulsification, hydrodissection and hydrodelaminations were performed to separate the cataracts from the surrounding capsule. A phacoemulsification probe was used to fragment the cloudy lens using ultrasonic energy, and the lens material was removed via irrigation and aspiration. Intraocular lens implementation. Following lens removal, viscoelastic solution was injected into the anterior chamber to maintain space. A lens comfort extended depth of focus. Acrylics intraocular lens was inserted into the capsular bag to restore visual function. Verification. The surgeon confirmed proper positioning and centration of the intraocular lens. The anterior chamber was checked for stability and remaining viscoelastic material was removed. Closure. The corneal incision was small and self-sealing, so no suture were required. Post-operative antibiotics and anti-inflammatory eye drops such as moxifloxacin and prednisolone acetate were applied, and protective eye shield was placed over the operative eyes.
For surgical instrument use, we have basic ophthalmic instruments such as the Barracker wire speculum, a spring-like instrument used to keep the eyelids open and retracted throughout the surgery. Next is Castro Viejo caliper, used to precisely measure the corneal diameter or the size of the incision site. Then Bishop Harman forceps, small tooth forceps used to grasp the conjunctiva or stabilize the globe. Next is fine suture scissors. This is extremely sharp, tiny scissors used for any delicate tissue dissection if needed. Next is we have specialized Phaco instruments such as the Phaco emulsification handpiece, the star of the show. It uses ultrasonic energy to vibrate at high frequencies, breaking the mature cataract into microscopic fragments while simultaneously aspirating them out. Then keratome 2.4 to 2.75, a diamond or steel blade used to create the clear cornea incision mentioned in the technique section. This incision is usually self-sealing. Next is side port blade 15 degree, used to create a secondary smaller stab incision for the second instrument to enter the eye. Then cystotome or Otrata forceps. It is used specifically for the capsulorhexis step, creating a perfectly circular opening in the lens capsule to access the cataract. Next is chopper or Nagaraja chopper, held in the non-dominant hand through the sideboard. It stabilizes the lens and helps chop the dense nucleus into smaller pieces for the Paco tip. Then viscoelastic injector, used to deliver the viscoelastic material into the eye. This gel-like substance keeps the eye inflated and protects the corneal endothelium from the ultrasound energy. Then we have IOL inserter, a cartridge, a plunger-like device used to fold the lens comfort, adopt acrylic IOL and inject it through the tiny incision. Once inside, the lens unfolds into its permanent position. Then for the roles and responsibilities of the nurse, for um, for preoperative nursing responsibilities, we should identify the patient identification and site verification, because accurate patient identification and surgical site verification prevent wrong patient and wrong site surgery, which are serious medical errors. Following the universal protocol ensures that the correct patient receives the correct procedure on the correct eye, thereby enhancing patient safety. Next is pre-surgical ocular preparation. These medications dilate the pupil to provide better visualization and access to the lens during surgery. Adequate dilation allows the surgeon to safely perform capsulorhexis and phacoemulsification while reducing the risk of trauma to intraocular structures. Then, physical preparation and baseline assessment, because obtaining baseline vital signs allows comparison during and after surgery to detect early complications such as hypertension, hypotension, or cardiac instability. Removing facial makeup and jewelry prevents contamination of the sterile field, while proper positioning ensures patient comfort and stability during the procedure under local anesthesia. Then we should inform consent verification, because verifying informed consent ensures the patient understands the nature of the procedure, expected outcomes, risks, and alternatives. It also fulfills legal and ethical requirements for patient autonomy and protects both the patient and healthcare providers. Next is for intraoperative nursing responsibilities. We should maintaining the sterile field, because strict aseptic technique prevents the introduction of microorganisms into the surgical site. Because the eye is highly sensitive, contamination can lead to post-operative infections such as endophthalmitis, which may result in permanent vision loss. Then instrument management, because proper handling and preparation of ophthalmic instruments ensures smooth surgical flow and precision during delicate eye procedures. Efficient instrument management reduces operative time and minimizes the risk of surgical errors or tissue damage. Then sponge and needle counts, because counting surgical materials prevent retained foreign objects inside the surgical field. Although cataract surgery involves small instruments, verification ensures patient safety and adherence to surgical safety protocol. For circulating nurse responsibilities, we have equipment calibration, because ensuring the Paco emulsification machine and surgical microscope are functioning properly allows the surgeon to accurate fragment and remove the cataractose lens. And malfunctioning equipment could compromise surgical precision and increase the risk of complications. Then medication assistance. Viscoelastic maintains the anterior chamber depth, protects the corneal endothelium, and provides space for surgical manipulation. Intracameral lidocaine provides local anesthesia within the eye, minimizing patient discomfort and preventing sudden eye movement that could compromise the surgical field. Then we should monitor. Continuous monitoring allows early detection of anxiety, pain, vasobasal reactions, or vital sign changes. Since the patient remains conscious, reassurance and prompt intervention help maintain patient stability and prevent movement that could interfere with a delicate ocular procedure. For post-operative nursing responsibilities, such as initial clinical assessment. So early assessment allows prompt identification of complications such as bleeding, infection, or increased intraocular pressure. Immediate recognition ensures rapid intervention, preventing deterioration of visual or surgical outcomes. Then protective shield application. The shield protects the operative eye from accidental trauma, rubbing, or pressure while the anesthetic effects are still present and sensation is reduced. This prevents disruption of the surgical incision and reduces the risk of infection. Then administering the first doses of moxifloxacin and prednisolone. So, moxifloxacin provides prophylactic antibiotic coverage to prevent postoperative ocular infections such as endophthalmitis. Next is prednisolone. This reduces inflammation, swelling, and immune response following surgery, promoting healing and improving visual recovery. For immediate post-operative nursing care, we have two problems. First problem is risk for injury related to visual impairment and post-operative sedation anesthesia. Orient the patient to the recovery room. So this is our responsibilities as a nurse. Orient the patient to the recovery room layout. Keep the side rails up and the bed in the lowest position because post-operative patients may experience blurred vision, dizziness, or disorientation due to the sedation and the presence of an eye shield. Orienting the patient to the environment helps reduce confusion and anxiety. Keeping the bed in the lowest position with side rails up helps prevent accidental falls or injury while the patient's mobility and vision are still impaired. Next, our responsibility is to provide one-on-one assistance when the patient first stands up, as the eye shield or the left eye significantly alters depth perception because the eye shield and temporary visual disturbance reduce binocular vision and depth perception, making it difficult for the patient to judge distance and balance. Close assistance during initial ambulation ensures patient stability and prevents fall, which could lead to trauma to the operative eye or other injuries. Next is our responsibility is to teach the patient to avoid the Valsalva maneuver, straining during bowel movements, coughing, sneezing, and avoid bending at the waist. Because these activities increase intraocular pressure. A sudden rise in intraocular pressure can stress or rupture the surgical incision, cause bleeding, or displace intraocular structures, potentially compromising the surgical outcome and delaying healing. Then for our Second problem, risk for infection related to invasive surgical procedure or clear cornea incision. Our responsibilities as a nurse is we should teach the patient and family the no-touch technique, never touching the tip of the eye drop bottle to the eye or eyelashes, because avoiding contact between the dropper tip and the eye prevents contamination of the medication bottle with microorganisms. If contaminated drops are reused, bacteria can enter the surgical site and lead to serious postoperative infections such as endophthalmitis, which may threaten vision. Then our next responsibility is to emphasize strict hand washing before and after any contact with the eye area or medication. Proper Proper hand hygiene reduces the transfer of pathogens from the hands to the operative eye or medication container. Since the eye incision is still healing, maintaining clean hands helps prevent infection and promote safe recovery. Then instruct the patient to report warning signs immediate such as sharp or sudden eye pain, increased redness, or sudden decrease in vision. These symptoms may indicate early complications, particularly endophthalmitis or other postoperative problems. So early detection and prompt medical treatment are critical to prevent permanent vision loss and preserve surgical outcomes. So our goal, this would be our goal, the patient outcome and also evaluation. For patient outcome, we should uh, look for the surgical success. So the patient successfully underwent phacoemulsification with insertion of an intraocular lens with zero blood loss and no intraoperative complications. Then we should assess their visual status. The patient reported minimal discomfort, the operative eye was protected with a shield, and no immediate swelling or excessive tearing was observed. Then, stable vital signs. This would be the patient outcome. Post-operative vital signs remained within the patient baseline range. Next is knowledge competency. The patient and caregiver correctly demonstrated eye drop administration and verbalized understanding of activity restrictions. Then follow-up plan. The patient is scheduled for a day one post-operative check-up with their doctor. So that's all. Thank you for watching and listening.